On the slide that said that you use I thought it was radiation and palliative.
Yes.
What would you be radiating? I mean, in palliative care, you're trying to ease the, you're not doing anything extraordinary. So what is it you're trying to accomplish in that chemotherapy?
Or chemotherapy or radiation, or either?
Radiation.
Okay. Yeah, so we think of palliative, the important concept even, we actually even offer surgery in the palliative setting, in that you can see, if the bile ducts are blocked or the intestines blocked. So sometimes I've done it where I have to do surgery to make a connection from the stomach to the intestine to relieve that blockage. People like Dr. Williamson, they can put a stent in. So let's say there's a compression of the intestine. They can put a stent in to keep that open. Same thing. Correct, yeah, and then same thing with radiation, because let's say there's a big mass and it's involving the nerves. So someone could get really bad back pain. And so if you radiate it and it shrinks down a little, I mean, we're not thinking that it's gonna go away completely, but if it shrinks down and it's not compressing on structures or nerves, then they might get relief from that. So that's how how radiation can be used in a palliative setting. Anything else?
Yes. What would be a recommendation for someone who had a pancreatic cyst and was concerned about the future, didn't know if that might lead to nothing in the future or might lead to something bad in the future? I mean, obviously, be in contact with your doctor.
So the question was about if someone had a pancreatic cyst, what should that patient do, correct? To worry about it, to not worry about it. Number one is, so there are many variables. The number one variable is what type of cyst is it? There are different types of cysts. There are cysts that are benign and they are never going to cause any harm, and a lot of them can even go away with time. There are cysts that are benign, they may stay there forever and not do anything, and then there are cysts that are potentially pre-malignant. So we try to differentiate what type of cyst it is. And some of that is evident based on the image that we have, like the CT scan. It can give us an idea of what type of cyst it is. And then the ultrasound, the procedure that I do, can also give us information by sampling the cyst, because we can test it and figure out what type of cyst it is. Now, if the cyst is very small, even if it were a pre-malignant or a precancerous cyst, the chance of that turning into cancer in the next few years is so low, the risk of doing the endoscopic ultrasound are probably greater than any chance of that turning into a cancer. So at the very least, we follow it, with an MRI or a CT scan every year or two, and just, ensure that it's stable. If it starts to grow, certainly we act upon it, do the endoscopic ultrasound, or even just go straight to surgery. If you have a young patient that we know has a pre-malignant cyst, those patients will probably go to surgery more often just because they have maybe 50, 60 years. They have maybe 50, 60 years that you will have to monitor that. If you have an 80-year-old patient that has a cyst, the likelihood of that cyst turning into a cancer is pretty low. So we may follow it, but the decision for doing surgery, you have a much higher threshold.
Yeah, so, as Dr. Williams said, there are certain types of cysts that don't become cancerous. So the pseudocyst is one that never becomes. A lot of people can develop that after they have pancreatitis. Also, the SC and the serous cystic neoplasm, those, when we see them, we never operate on them. The ones that are the concerning ones are they have mucin in them, so it's the mucinous, the MCN, and then the IPMN. So for us, from a surgical point of view, if it involves the main duct, the one that's sort of in the middle, those have a high chance for cancer. So no matter the size of that, those get removed, because IPMNs often have malignancy in them. So if we see it in the main duct, those get removed. The MCNs and the side branch, the ones involving the side branch like IPMNs, we usually follow those, and unless they're 3 centimeters or greater, we would remove them. And one thing that Dr. Williamson talked about in his talk is if there's a nodule. So if there's a solid component within the cyst, no matter the size, we may end up having to remove them. So some of those are automatically operated on and some aren't, and they're followed. And if there's changes where you see solid component to it, or if it gets to a certain size, then they may need to be removed. So knowing which kind it is, then you may just follow them. And if it changes, then you would remove, or some of them you don't need to even follow at all.
Thank you.
Did you say the cysts are removed laparoscopically or not? Did you say?
So if, for things like pseudocyst, if people have them, they can actually cause symptoms by pushing on the stomach. So that's something that Dr. Williamson might do is a cyst gastrostomy where they go through the stomach, and maybe you want to describe that a little. Or
Yeah, so if it's a benign cyst, if it's a pseudocyst is usually pretty much always due to pancreatitis or inflammation of the pancreas, and it forms as a reaction. It's an inflammatory reaction where a cyst forms, and usually those resolve with time. But if that, like Dr. Wai was saying, if that is big and it's causing symptoms, then we can drain them. And usually we can do it endoscopically with the ultrasound. We actually go in the same method of sampling it with a needle, but we actually put a big stent across it, or a couple smaller stents across from the stomach into the cyst, and we drain it internally into the stomach. And so there's no cuts, on the abdomen or anything, and that'll generally help it resolve after time. But if we're not sure that it's a pseudocyst, then we certainly don't want to drain it, because we could drain it and it looks like everything's all good, but it turns out it's a malignant cyst or a cancer. So we want to be absolutely certain that it's a pseudocyst, pseudo meaning it's sort of a false cyst, before we do that drainage.
And then in terms of surgery, I'm glad you brought up the laparoscopic question. So, even with the cyst, let's say it's an IPMN, if it's involving the head of the pancreas, we often have to do a Whipple procedure for that. So again, it's dependent on the location which affects surgery. So laparoscopy, sort of in the last 10 years or so, we've really developed laparoscopy, even robotic surgery. And what that is just smaller incisions to do the same operation. For a lot of the ones at the tail of the pancreas, because we're not moving all those organs and making all those connections, we actually do a lot of those procedures laparoscopic. And so we go in with cameras and smaller incisions, and we actually you have to actually remove part of the pancreas with it. So it's hard, you can't really just remove this. It's drawn like, it seems like it's floating above it. A lot of it's actually in the inside of the pancreas. So you end up having to take a portion of the pancreas with it. There's some centers that are starting to do the Whipple laparoscopic and even robotic, but that still hasn't really caught on because it's such an involved procedure. So in the future, we may be moving towards all laparoscopic or robotic surgery for those things, but it's still not a common thing to do those laparoscopically. But more in the distal one, as you saw earlier, we're only making a small portion, we can do those laparoscopic. And sometimes you're limited by size. Let's say something's really big, it's a couple inches in size, you just don't have the room to do it laparoscopically, because when we do laparoscopic procedure, we have to pump the stomach full of gas, and you have to have room to move around and look around. If the cancer itself is so big, you're working with a small space. And I always tell people, it's like if you imagine a beach ball and you put a lot of stuff in there and you're just trying to maneuver inside that beach ball with little small instruments poked into there, you can imagine it's hard to do a lot of the procedures just laparoscopically.
What are the symptoms of a pancreatic cyst?
So actually, good question. This question is, what are the symptoms of a pancreatic cyst? It can be, you can have no symptoms, actually. That's actually the most common presentation, is that they're found incidentally. So somebody gets a CAT scan for some other reason, and they see incidentally a pancreatic cyst. And that's why I say they're very common. 2 to 3% of CAT scans in some studies have been shown to have pancreatic cysts. MRI is a lot higher than that. Most of those patients don't have any symptoms. Where you get symptoms is when they become so big and they start pressing on other organs or blood vessels or what have you.
Excuse me, I can answer that question from experience. Okay, for me the symptoms were a dull belly ache, but not low down, high up behind the stomach. In other words, just a sort of dull kind of back here and the high up. That's about it, but it wouldn't go away.
So it was always
Just going on and on and on. And I had a cyst, which was, and I had a endoscopy, and I had the liquid removed.
Okay.
Yeah, through the needle procedure.
Yep.
Luckily, I was asleep.
Yes.
It was benign. Where everything was no cancer cells, but a lot of liquid in the cell, in the cyst. A lot of fluid in the cyst, but no cancer cells.
Yeah, these cysts can be very big, and we used to think that size, if the bigger the size, the higher the chance of cancer. there's some data coming out now that says that's not necessarily the case. On the whole, it is. The larger the cyst, probably the more likely it's going to turn into cancer at some point. But we see a lot of very big cysts that are benign and won't turn into cancer.
Yeah. Would you talk about causes for inflammation of the pancreas? You said that was one of the predisposing.
So, the question is the causes of inflammation of the pancreas. So pancreatitis. So that's the main pancreatitis. Pancreatitis is sort of a catch-all. I mean, there are many different causes of pancreatitis, but there are varieties of pancreatitis. You can have an acute pancreatitis, which is an onset very abruptly from some problem, usually an obstruction of the pancreatic duct for some reason, like a gallstone. Or, on the other hand, somebody that's an alcoholic that drinks very heavily can get an attack of acute pancreatitis. And that can be a highly inflammatory state where the pancreas is very inflamed, and patients usually present with very severe pain. I kind of rank it up there with kidney stones and childbirth as far as pain goes. That's a little bit different than chronic pancreatitis. Chronic pancreatitis is more of sort of a fibrotic or an ongoing low-level inflammation. It may be a lot of damage or scarring in the pancreas itself. We know a lot about it, but there's probably a lot more that we don't know about it. But we can tell based on certain characteristics of the pancreas itself, and also it doesn't produce enough enzymes to break down food in most cases. It just doesn't function correctly. Those patients, we just know that they have a higher risk for cancer, and part of it could be inflammatory because there are a lot of other diseases where inflammation is a predisposition for cancer. And so, the theory is that that's part of the reason. It may not be the only reason, though, that's why patients can develop cancer with chronic pancreatitis.
And one thing I add is that even some people with cancers can develop pancreatitis from that. So they can get bad inflammation if the ducts are blocked. So there's inflammation because what happens is a lot of the inflammation is because those digestive enzymes leak in and they destroy the pancreas. That leads to the inflammation. So that also makes surgery harder for us because some people have a lot of inflammation, and that inflammation in the pancreas makes it stuck to all the other organs. So that's another level of complexity. Also, when people get radiation, it also causes scarring and inflammation wherever the radiation beams go. So that also makes surgery more difficult when people have a lot of inflammation.
You mentioned itching as one of the symptoms. I just heard of that from a friend who had developed pancreatic cancer.
Yeah, the question was itching with pancreatic cancer. It's mainly from the jaundice, because when you have the ducts that are blocked, then the bile can't get out of the liver and it gets absorbed into the bloodstream, and so it's that high level of we check bilirubin levels, and so when the bilirubin is really high, it can induce the changes in the skin color, and that's what causes the itchiness.
The bile salts basically is what's thought, the deposition in the skin is what's thought to cause the itching.
And that's why I was saying earlier that the gastroenterologist might put a stent in, and once it relieves that obstruction, the bilirubin goes back to normal, the jaundice goes away, and the itching will get better.
Yes.
A 36-year-old niece was diagnosed with pancreatic cancer. Originally, she had a terrible back pain, and that deluded everybody because they were treating her back pain. But finally, they discovered that she had that, and now it's pushing on the duodenus, which is affecting digestion, and has growths and what. And just this week, spread to some lymph nodes. That sounds pretty final, doesn't it?
Yeah, so the question is, a family member actually had back pain and then ultimately was found to have pancreatic cancer. It seems to be involving the lymph nodes. And we both talked about it a little bit earlier, because where the pancreas sits, it's a retroperitoneal structure. So we divide the abdomen in the peritoneum means sort of in the belly. Retroperitoneum is in the back part. So because of where the location, it's behind the stomach, it's sort of closer to where the spine is. A lot of people don't have belly pain, they actually have back pain. And so, I'm not saying that everybody now that has back pain you have pancreatic cancer, But, you know, if, along with the other symptoms like the jaundice, the weight loss, those would be things that would make you suspicious. And if it's involving lymph nodes, you know, it's going to be in a higher stage. And so definitely it's probably a little bit more advanced. And it all just sort of depends on the size and the involvement of blood vessels.
And I would also, I mean, I'm sorry for that, you know, misfortune that you said was your niece that was a young age. I would recommend that family members get tested as well, at least, especially if there's other family members with the pancreatic cancer, because oftentimes if patients, when they're diagnosed early, I don't know, you know, usually they would test the actual patient. You can do genetic testing to see if there's any specific gene abnormality that is present, that's mutated, and you can use that as a reference point to test other family members as well.
Yeah, and that's what I was saying. I mean, you might be young and the only person, then there may not be a genetic component. So we sort of, a lot of times, if they're in the younger ages, like we said earlier, 40s, 50s, or even 30s, that's not common to have happen. So then we start thinking about genetic issues, and so you kind of have to look into the family, have other people. So I often, you know, a common one is the BRCA, the breast cancer gene. So when people have that, you know, so you might be asking questions, not just if other people have had pancreatic cancer. So if other people had breast cancer or other cancers, and then you're seeing a pattern, then we start suspecting genetic causes. It's, you know, and I tell people just because you're young, it doesn't mean it's necessarily genetics, but that's something to think about as well. Do you have another question?
You know, the procedure where you go in with the tube into the, you know, the GI tract down into the stomach behind to get to the pancreas. Given the fact that they had problems a month ago with that procedure where they weren't sure they cleaned the thing right. So are they changing the cleaning thing with this now too?
Good question. The question was about the infection risk with a certain type of scope that's been in the news over the past 6 months or a year. That was actually with a specific scope, the ERCP scope. We haven't had any problems with the to open up the bile duct. So we sometimes use it in these patients with pancreatic cancer. And the problem is with the newer generation scope, there was a specific part that wasn't the way that the scope was designed, the newer generation, the cleaning methods weren't appropriate. Yeah. And so we at Hartford Hospital and the Hartford healthcare system in general, we've taken all of those scopes out of service, and we're using the older model, which is pretty much as good. You know, we can, the resolution isn't as good, the camera isn't as great, but for the most part, you know, we can do what we need to do effectively. And we've, you know, we've screened all those patients that had the procedure to see if they have that infection. I don't believe anyone has turned up positive for the bad bacteria that we were concerned about. But yeah, certainly that, you know, there's always risk. Like I tell my patients, there's always risk, obvious risk and not so obvious risk with any procedure. And I go through that with them. And you know, the risk of infection is very, very low, but that's always a possible risk with a procedure I do or a surgical procedure as well.
And just the other thing to remember, I always tell people the GI tract is actually full of bacteria. Mm-hmm. And so in the bile normally there's bacteria, and a lot of times when people have a bile blockage, they can get a bad infection because the bacteria right in the bile gets absorbed into the bloodstream. So by nature, it's technically, you know, going into the GI tract, it's already a dirty procedure where there's a lot of bacteria.
I guess it's just if you pass it on to somebody.
Yeah. And it may be introducing a new organism, or they may already have similar. And a lot of times infections happen when people have a weakened immune system. So for the average healthy person, generally, you know, you're not likely to get sick.
You know, Dr. Levine, I think it's Levine down up at UConn, he was doing some research where for people that had a history of colon cancer, and they were trying to develop they were trying to develop a camera that they used up in space. I forgot the name of the camera, where they could pick up if the patient had one or two cells, cancerous cells, and if they have a history in the family of everybody getting cancer, then they would take it out. Were they using that kind of cancer? I mean, were they using that kind of camera in that new one that they couldn't clean as much as they would have liked?
So the question is a specific type of camera or scope that's used to pick up microscopic types of cancers. No, we weren't using that specific scope or camera in our ERCP procedures. There's several new sort of scopes out, or in trials or research, and some of them are used in some of the big centers, like I don't know if it was called a confocal laser endomicroscopy.
I don't remember him giving the name.
That's
Sounds fancy
that's
enough
one.
to be
Yeah,
it.
that's
Something so good they could find something in space. If
Yeah.
they can find it in space, they can find it in your.
well. With that, you can look at very small areas, and it's kind of like doing in real time doing pathology, where usually we take a biopsy and we process it, and the pathologist at a different time looks at it under the microscope. That's a scope that you can kind of put the probe up to it and look at it very in very small portions. But there has been some studies with that type of modality in pancreas disease, and actually you do it by putting the needle. You have to actually puncture the pancreas with a needle, and it's a larger caliber needle, and you advance that small caliber probe into the area, but you have to have a target of interest. In most cases, it's not going to add much. It's not going to be useful as a screening tool.
More esophageal stuff too.
Yeah, esophageal stuff. We use a lot of it's being used in Barrett's esophagus, where we know that's a potentially pre-malignant condition, and we want to interrogate it very closely, and you can interrogate it with that.
And the other thing just to remember, no camera can really detect cancer. You have to actually have a sample of it. So the cameras might be, as you said, more fine to pick up smaller cells, but in the end, the diagnosis still has to be made by a biopsy. Yeah.
Yes.
I just learned that a high school classmate of mine was cured. She had surgery, was cured of pancreatic cancer at Hartford Hospital. However, it did turn sad. She was having a simple procedure done. Not even all the family was there with her. She never woke up from the anesthesia. This all happened within the last month.
Sorry to hear about that.
Wasn't that, she was cured, she was cured of the pancreatic cancer.
Sometimes that I've seen that when a patient, a young child, came in for just a minor cosmetic procedure on her face, lip or something, and she died. And what happened was, we think the IV got infiltrated, so she didn't get the medicine that pulls her out of that deep sleep. You got to pick them up out of that deep sleep, and so maybe that's what happened.
She was my age, 80.
Yeah. The comment was a catastrophic event not related to the cancer after a cure, and again goes back to the risk of the procedure. They're very, very low risk. The procedures that I do, at least, are very low risk, but it's not no risk, and you always have to weigh the risk and benefits. And that's why even with cysts, if they're very, very small, the risk may outweigh the benefit of doing a procedure to look at it, rather than just follow it with CAT scans.
With that's a good question, though. Do you think now the anesthesias on their pumps that, or whatever, has to watch that medicine going in intravenously, do they have a bell or something that could ring if it's not pumping right? They do.
I think as you said, it's a circumstance. It may not be the anesthesia that they didn't wake up from, but when you induce anesthesia, there's relaxation on the heart, there's stress on it. So they may have had a heart attack, which made them not wake up. So a lot of it may not be medicine related, but it's the body's response to the medicine. And so, they're monitored during it. So a lot of people, why they have they may die from anesthesia is that it just overwhelms the system, and the response that they have to whatever procedure, it stresses the system out. It can induce the heart to stop. So it's usually more that. Anesthesia, you can tell because they're monitoring you in every operation. They look at your heart rate, your breathing, all your vitals. So if you're breathing too fast, or there's signs that maybe there's not enough anesthesia, they can increase it. So there's ways that they can tell besides looking at the medicine dripping in whether there is an effect.
Yes.
In my family, it's an inherited, it's hereditary. My maternal grandfather died in Ireland of probable pancreatic cancer at age 42. That was in the mid-1920s. The family emigrated to the United States. His son, my uncle, died in New York of pancreatic cancer. My mother died in 1988 of pancreatic cancer. 2 years ago, my mother's niece, my cousin, died at age 80 of pancreatic cancer. She was talking to me on the phone. She lived outside of, I live in Cromwell, Connecticut, and she was outside of, in Ridgefield, outside of Danbury, and talking on the phone and with emails. I was finding out her symptoms. I knew before she knew, and the family knew. I just knew, and that's when she died. She lasted 2 months.
So yeah, somebody has a strong family history of pancreatic cancer. So
She had only been in the hospital. She died at 80. She had only been in the hospital 6 times to have children. She had good health.
so there's probably some genetic component there.
There's 4 relatives in 3 generations of my family.
Yeah, so people in your family, you know, may benefit from screening procedures, certainly because the incidence is so high.
That's why I'm here.
Right, right.
And the other option is if, you know, your physician, they can send you to a genetics counselor because they can kind of look through your family history, pick up all the subtleties, and maybe even suggest tests that can be done. And if there is, you know, a particular mutation that you have in the family, then that would be a reason to get into a high-risk screening protocol.
That's why I'm very pleased with this program. The first 3 were filled, and then you had the first 2, I guess, but then you had this one, and I was just thrilled to be a part of it.
Yeah, family history.
Thank you very much.
You're welcome. Yeah, family history is a very big component of our history taking now. It's especially in the cancer field. 20 years from now, it may not be so much because we may have we've cracked the genetic code, but we still don't know all the mutations, the permutations of it. But it may not be as important in the future. But for now, it certainly is because you know these can lead us to certain diagnoses or certain mutations that can put patients at risk.